Hello and welcome to today's webinar, Risk Adjustment Gets Usable Data at Last. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. And you may ask a question at any time during the presentation by typing your question into the Q&A box, which is located on the right side of your screen, and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement. It's located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. And we're very fortunate to have with us today Leah Hannum, Director of Government Funding Operations at Blue Cross of Idaho, and Jonathan Thompson, Head of Analytic Solutions at Abacus Insights. And at this time, I would like to turn the floor over to the speakers.
Hi, everyone. Thank you all for joining. Super excited for you to attend today's webinar. For today's agenda, we will first highlight the inherent problems in risk adjustment data today. Next, we will discuss how BCI and Abacus collaborated to build a risk adjustment data solution that solves for these problems. And finally, we will discuss how you can work to improve the usability of your own risk adjustment data. But first, we will do brief introductions. My name is Jonathan Thompson, and I'm the head of analytics at Abacus Insights. I'm an actuary by training, having worked in both the payer and provider space throughout my career. Abacus is a company that specializes in supporting payers in their data journey. Over 20 million members are on our platform across all clients. Abacus is a leader in data usability for payers, setting a new data standard for healthcare. Now I'll hand it over to Leah.
Hi, everyone. I'm Leah Hannum. I'm the Director for Government Funding Operations here at Blue Cross of Idaho. This is the risk adjustment team here. I've been in healthcare for a little over 19 years and focused on risk adjustment for the last 10 of those. Just a little quick thing about Blue Cross of Idaho. We're a not-for-profit mutual insurance company solely based in Idaho. We cover around 600,000 members across all lines of business, including about 60,000 in our MA and duals populations, and about the same population in our ACA line of business as well. All right, so what are our goals of risk adjustment? I'm sure those of you that work in risk adjustment are probably familiar with these goals. Primary one, of course, is ensuring that the payment we're receiving from government risk adjustment programs is accurate and accurately represents the acuity of our membership. We want the ability to meet providers where they are in their risk adjustment knowledge, program participation, and by using data to determine what data and content we need to deliver to providers to help support them. We have a goal of conducting oversight and performance reporting on all of our risk adjustment programs to ensure that they're delivering the results that we're expecting. Ability to quickly identify and take action on any opportunities or risks that need to be assessed, as well as create innovative solutions that help support our goals. And sharing data with other areas of the company, such as our care coordination, quality, and STARS teams. And last but certainly not least, ensuring that we're in compliance with audits and reporting requirements. So what was slowing us down in meeting our goals? Our data team was spending a significant amount of time moving, merging, and standardizing data. As you might know, there's a variety of data sources that support risk adjustment. You have CMS data, you have claims and membership data coming from your in-house systems, you probably have vendor data coming in, and all of those have different refresh schedules. Because of the need to merge all of this data, it was taking close to a month for us to collate the data and create our output metrics and reporting for both internal reporting as well as for providers. And that was creating some provider frustration. If they had felt like they had addressed a gap the prior month and refresh schedules weren't allowing us to make sure that we were showing that gap as closed or addressed, created a little bit of mistrust in the accuracy of our data. Because we were spending a lot of time moving data and standardizing it, that left very little time for new innovation, new projects, the fun things that my team wanted to work on, or the ideas that they had for how to move things forward. And it was just creating a lot of slowness and frustration. So we looked at what was causing our problems, what was really holding us back. The biggest issue that was causing the most frustration was our siloed data. So our data lived in 9 different servers or 24 databases across 9 different servers. And so sometimes in the process of building out reporting or metrics, or in troubleshooting when something went wrong, we'd find ourselves moving the same data multiple times, or creating various copies of partial data sets that then caused greater confusion. We also have several vendors that help support our risk adjustment program. So each one of those vendors and then all of our CMS data are different integrations. And those integrations, a lot of them were manual. And then once we had collected the data, it takes a significant amount of time to join it. The data sets were not always consistent in their conventions or how the data was formatted or populated within the fields. And like everybody knows, IT resources are shared across the company, and competing priorities at BCI meant that we did not always have access to the tech resources when we needed them to help build out additional functionality, automation, and efficiencies. So risk adjustment is heavily a data game. If you don't have efficient access to the right data at the right time, it can be very hard to meet your goals. There's a lot of focus on risk adjustment programs. Recent reports in OIG, MedPAC, as well as proposed legislation is highlighting the higher stakes that currently exist for the risk adjustment program. I'm sure most, if not all of you, are aware CMS released a rule on RADV earlier this year that includes extrapolation for both CMS and OIG conducted RADV audits. And the new rules increase the risks of not finding and not resolving unsupported diagnoses. That was a big awareness moment for us that we had some gaps to fill. And then, of course, as I mentioned earlier, data timeliness and data accuracy can lead to provider frustration, and that leads to loss of traction in provider engagement programs. It's problematic, especially if those providers have value-based contracts and are reliant on BCI data in order to meet their own goals.
So as Leah just articulated, in risk adjustment, there are high stakes in getting the data right. You just can't fudge the data. Oftentimes people think they have great data or ignore the fact that they have bad data. Abacus prides itself on setting a new standard for data usability that are based on the 6 criteria shown. Is your data complete? Does your data sit in one single comprehensive data warehouse? Not just your membership and claims data, but also vendor data, which is in a proprietary format, be it retro chart reviews, identifying suspect condition, HRAs, as well as CMS files. All this data needs to play nice with one another by having a consistent structure. Also, complete data entails key metrics. The data solution automatically calculates risk scores, provider attributions, and other metrics that are vital to risk adjustment. Is your data accurate? It's not just about accessing the data, but having it ready for use with data validation upon ingestion. Abacus is able to run certain automated control checks when data is ingested to flag any errors or discrepancies, like subscriber ID or phone number. Does it have the correct number of digits? Does it have any letters? All these checks are being done beforehand to ensure the end user has confidence that the data solution is accurate and ready for use. Next, is the data timely? How fast can you see updates in the data? Super critical in risk adjustment when you are tracking members' open suspect conditions or the number of members without an annual wellness visits. These metrics need to be timely if it's going to be used by the providers as well as the internal team. We need to understand that out-of-date data is bad data. Delays in calculating risk score or tracking closure of suspect conditions will impair teams' ability to achieve goals. The data solution designed to quickly integrate new risk score models upon release by CMS. So as new models do get released, that is completely automated and reduces significant work by the risk adjustment team in incorporating that new CMS risk score model. Next is data relevant. Is the data relevant? It has to meet the needs of your business unit, providers, patients, vendors, and other stakeholders. You want an intuitive design for this data solution. In terms of risk adjustment operations, you're not looking at utilization or claim dollars. The focus is really on disease captured HCCs, suspect conditions. Understanding the grain of the data is critical to how it will be used. And then finally, is your data versatile and use case agnostic? The data solution should be flexible enough to support a variety of end users. Different use cases have different users. The data solution must reconcile these differences when calculating metrics and designing table structure. From the highly technical end user that wants the ability to go into a detailed claims analysis versus the non-technical operator who simply wants to access key business value metrics that help drive performance. For BCI, this means accessing the data solution from both Tableau as well as Snowflake. Moving on. So before we go into the details of the data solution, I wanted to highlight some key factors that led to the success of our partnership with BCI. First and foremost is establishing a relationship. Abacus and BCI were very collaborative throughout the design and development phase of the data solution. During a month-long discovery phase, Abacus gained an understanding of BCI's data and how they used the data, which helped Abacus define the business requirements for the solution. We first did an inventory of all data sources being ingested and distributed on the solution, understanding what is the data format and layout. Is it Parquet, CSV, Excel? What is the cadence of the data being updated? Is it weekly, monthly, or is it on an ad hoc basis? And how does it get updated? Is it a full refresh, or is it something that we append to the existing data? We also define the reporting needs and the business use cases. Some of the use cases are universal to risk adjustment, like tracking risk scores, tracking captured HCCs, while other use cases were unique to BCI, like supporting the data for BCI's specific value-based programs. Creating common definitions for key features and components was critical. Learning terminology specific to BCI was also important. In addition, during the development phase, we also had frequent touch points. Getting to know the business and technical owners helped us quickly iterate. Sometimes small and nuanced problems popped up, and being able to meet up with the business owner, even for 15 minutes, allowed us to quickly remedy the issue and hit our deadlines. Another key success factor is just the underlying data that supports the data solution. So first is the ability of the Abacus platform to ingest any and all data sources. These data sources can be in any format, and because we are working on the cloud, in any size. Abacus has the ability to ingest, healthcare operation systems, claim system, vendor data, CMS. In addition to ingesting, Abacus then maps all this data into a unified data model, allowing all data sources to be consolidated into a single comprehensive data warehouse with standardized fields and consistent structure across tables to allow for all data to play nice with one another. An example is, does every table have consistent member identifiers, be it subscriber ID or MBI? And are all key values in the correct format? Now, the data solution, 80 to 90% of the data solution is out of the box. with the remaining being specific to the client. Things like provider attribution, member months, line of business mapping, those will always be specific to the client, and Abacus can easily configure the solution to meet the client's needs and unique logic. And finally, the other advantages is that the data can be used for an array of use cases, be it value-based or financial projections and analysis. The data is structured into various subject area marks depending on the use case or needs of the end user. In addition, the way the end user interacts with the data also accounts for the design. The end user may use Tableau for standard operational reporting or Snowflake for more detailed analytics. Building out tables specific for Tableau was critical for the usability. You don't want to necessarily plug in your claims table directly into Tableau because that would really reduce the performance of Tableau. Rather, we develop specific reporting tables that would hook into Tableau for the specific reporting needs of that Tableau. Finally, the Abacus platform offers better time to value and lower total cost of ownership. The Abacus platform offers a cheaper and faster way to scale and level up your risk adjustment operations compared to other alternatives. Leah?
So we've made a significant amount of progress and gains in the efficiency and accuracy of our data with this solution. As JT mentioned, the data moving from piece to piece through there allows us to refresh data as near to real-time as you want to happen. So for example, our claims data can go over daily if it wanted, it can go over weekly. And then that data percolates up through all of those Snowflake tables and into the reporting tables and into the Tableau very quickly. So we're no longer waiting for data to refresh in different databases in order to be able to capture the most up-to-date data. This has allowed us to increase the frequency in which we're monitoring things like suspected condition capture, year-over-year metrics in our reporting for annual wellness visits or members without visits, recapture rates. We're able to incorporate through this progress additionally the provider feedback data. This is something that we had never had prior to working with Abacus, was the ability to import provider feedback from our prospective programs back into the data so that we can use that for decision making and what and how we're sharing suspected data in the future. So our providers are able to tell us if a condition has been resolved, if it's in remission, if they're not aware that that has been a captured condition prior, or maybe they have, the member has picked up a new diagnosis from a specialist that they're not aware of. They can give us that feedback, and then that can help us engage with the provider better. And by the providers seeing their feedback being utilized in the programs and reporting, we're getting better engagement from them as well. Which also improves the job for my provider engagement team. It makes those interactions with providers much, much easier, especially now that the data accuracy is also improved from the frequency of the updates. Our on-demand Tableau reporting, we've had some Tableau reporting prior to this. A lot of it was still manual efforts in the background. So the on-demand Tableau reporting and the automation that's supporting them gives me up-to-date metrics. Where are we on our risk score capture? How does that compare to where we were at this point last year? And I can slice and dice in different memberships so that I can make sure that I'm comparing like to like. We're more easily able to identify any kind of outliers in our data because it's very quickly to filter through or change the views on those Tableau reports to identify if there's anything that stands out. And then one of the best benefits, in addition to the provider feedback report, is that my team now has capacity to actually focus on what's causing those outliers. So they have the ability to dig into the data, They can do that through some of the reporting tables that have been built, or they can just go directly to Snowflake in the SAMs and really kind of research that data and figure out what's driving the anomaly. And then we can make plans and take steps to address those things. We have better, more frequent reporting on the performance and impact of all of our risk adjustment programs. So how is our retrospective chart review program doing? How's our IVA audit on the ACA side doing? How are we doing on chart review? Are we concerned about meeting the timelines of those audits? Are we concerned about meeting sweep dates? What are the progress of those? How's our in-home assessment doing as far as completion rates? Do we have care management follow-up happening on our in-home assessments if it was a referral from the nurse practitioner that did the visit? And then what are the care management outcomes for those as well? So the home assessment data goes to our care management team, and then they can reach out to the member and make sure that they're getting the care that they need. And then also, how are our prospective programs that our providers are working on, focusing on as well? How are those performing? So are we getting the engagement that we need from providers? Are we getting the capture on the HCCs? Are we getting feedback on them? All of that is so much more efficient now than it was in prior. And then JT, I think, mentioned some of the customization, the 10%, 20% of this solution that can be customized. Some of the customized logic that we were not able to meet before is actually logic that's in our value-based contracts with providers. So we contracted with them on a certain way of calculating an annual wellness visit rate, but then we weren't able to provide reporting without some manual workarounds to actually calculate that for them. So we've been able to build customization for annual wellness visit rates, PCP attribution, and make sure that we're getting that accurate, timely data to our providers for those, for their performance on their value-based contracts.
So next is, how is this all possible? First, automated on-demand metrics, including risk scores, captured HCCs, MLR reporting, provider attribution. Automating these key analytics increased timeliness of data and accuracy, and allowed the BCI team to focus on more advanced analytics now. Key automation includes tracking suspect conditions. So the data solution aggregates all sources of suspect conditions from a variety of vendors, dedupes all the suspect conditions, and then maps and identifies if that suspect condition has been addressed or not throughout the year. That way, the team has the latest list of open suspect conditions. Also with risk scores, we have a risk score engine that calculates the risk score on a year-to-date basis and is updated on a monthly basis, so the team can track at the member level how the risk score is looking for the population month over month over month. Next, format standardization and alignment. Mentioned this before, but this is critical. Allows the data to be consolidated into single data warehouse and have all the fields play nice with one another. A good example specific to risk adjustment is HCC codes. Some vendors might just use the number of the HCC, so 123, while others spell it out as HCC 123. The data solution automatically standardizes this across data sources to avoid any data wrangling in the back end. Automatically feeding the data to BI and other tools for easy drill downs and detailed analyses. Again, the data solution was designed with the knowledge that some reports would be directly used in the BI tool, which was Tableau. So we were conscious of performance when developing these tables. A good example is we have a reporting tool for percent of annual wellness visits completed by attributed provider. We created a single report table that sits within the data solution that is sorted only for AWV claims, Again, the logic being we don't want to slow down performance in Tableau by joining it to all the claims that exist in the data solution. Next, timely data updates. The data solution can update as fast as the data gets ingested. So as claims data gets updated weekly, as soon as the new claims data becomes available, all the changes to claims trickle down to all the various subject area marks within the data solution. So as we get claims, then we recalculate all the captured HCCs, how many AWVs have been completed, and also the suspect condition tracker. Bidirectional interoperability, including vendors and providers in their preferred format. A great example of this was the BCI's value-based program. So an output of the data solution is a list of all suspect conditions by attributed provider, sorted by their members. BCI sends out this data, which is all suspect conditions for providers panel, in order to get the provider to address these suspect conditions the next time the member is in the office. Once the provider addresses the suspect condition, the provider actually gives feedback and sends back to BCI this feedback that we are then able to ingest in the data solution and then match that feedback with the claims to ensure that data solution was captured. Again, timeliness is critical here, and by having timeliness, we can ensure that the provider is getting the latest list of suspect conditions and not wasting their time on suspect conditions already addressed. And with that provider feedback also, it's not just saying, yes, this was addressed, or no, this member does not have this condition, but sometimes the provider fills out some feedback that is more nuanced and not necessarily structured. We can bring in that feedback into the data solution that gives more context for the BCI team to understand whether or not this suspect condition is valid or requires more investigating. Another benefit that was possible was a complete view of financial impacts and ROI for vendors and internal programs. The data solution maps which HCCs were captured by which programs, be it retro chart review, AWV visits, value-based programs, HRAs, and then we can use this to understand the incremental impact to the risk score of each program and then compare it to the actual cost of the program to get better visibility into what is working, what isn't working, where should we focus our efforts. Is one vendor doing a better job than another? All that can be done now with the visibility in the data solution. And then finally, usable data for other payer teams. So there are various use cases that touch other teams at BCI, and the data solution can conform to those perspectives. So, core use case, you're going to want to know risk scores, demographic factors, HCC factors, any possible interaction hierarchies. But for clinical package, which is one use case, really you're just trying to capture, summarize and capture, what are the members' captured conditions, suspect conditions, and highlight these HCCs, but you're less concerned about the actual risk score, more clinically what can be done to support this member. And then finally, from the financial perspective, we have MLR reporting within the data solution. And again, from that perspective, yes, we're interested in the risk score, especially MA, as it directly correlates to the revenue, but more we're trying to understand MLR, profitability, and how the risk score is impacting that.
So I can't underestimate, I can't understress how important it was to have data that was readily accessible to other areas of BCI. Primarily, I think our actuarial team, because they're also data people, they like to dig into the data as well. So just output reporting or metrics wasn't good enough. And sometimes getting them access to our data sets that lived in sandboxes because we were moving data around was very difficult to share. So this has been another really big benefit to us. All right. As most projects do, we ran into challenges. I will say we didn't know what we didn't know heading into this. We tried to do a significant amount of prep. JT mentioned all of the research about what data sources we were bringing in and identifying their refresh schedules and the different components of them. But we, as we were trying to set up the connectors for those data sets, ran into a need for technical resources that we hadn't planned for in all of our project planning. So sometimes we needed a database administrator to turn something on or set up something a certain way. And we didn't know that until we ran into those problems. We, because of that, need to pull in additional tech resources outside of our original scope. It was very important that we engaged our IT leadership to make sure that they were not only aware and engaged, but understanding of what the benefits of this are and benefits to the risk adjustment program and how that can impact the rest of Blue Cross of Idaho. There were several incidences where we had to reach out to various help desks to figure out how to integrate technology. We talked to the Snowflake help desk, we talked to Tableau help desks, working on how to troubleshoot some of the connection issues that we had. This next one, cannot stress enough. You're building a brand new data warehouse or data source for your company. It is very important that you're not creating new new terminology and definitions that contradict your existing data. We got our data governance team involved way too late in the process, and that caused some rework that we had to do in aligning what fields were named, how they were used, how we were defining them. It took a lot for us to define line of business. The enrollee ID, your subscriber ID, member ID, there's a lot of various names for that. That was also a lot of other conversations. And I will have to say, there's things that are inherent to you in your job because you do it every day that aren't inherent to some of the tech resources or the people that you're partnering with on this. So we often missed on things that were very ingrained knowledge for us on the risk adjustment team that weren't necessarily obvious to the Abacus team or some of our BCI tech team. And then make sure that you have plan specific logic early. This kind of is a continuation of the last statement of making sure that your inherent knowledge is there. But we absolutely ran into challenges with defining.
And just to build on that, what we didn't know, a good example was the line of business logic, so assigning members to Medicare Advantage or ACA, unfortunately that wasn't as easy as just pulling a field in the claims or enrollment data. It did take a little more time and it was a lot more nuanced. And then data governance, determining if, if a certain issue is use case specific to risk adjustment, or should that logic span across all of the enterprise within BCI? Important because Abacus has also developed other data solutions for BCI, and having that data governance that spans multiple data solutions is critical when designing. Another thing I would say, plan user acceptance testing in an efficient way. Get ahead of what can be resolved before UAT as well. So naming conventions, making sure all necessary fields are included in all the tables, understand how issues impact all SAMs and reporting tables. So for example, if there is an error in the member eligibility table, that's going to flow through a bunch of tables that are more downstream. Knowing how that error impacts one table and then all the rest can avoid redundant testing. And then separate UAT for both the data solution as well as Tableau. And understanding also there's different things to test in both of them. Accuracy of underlying data for Tableau, its design and functionality, and the report accuracy, and understanding is the error within Tableau or is the error within the underlying data.
Yeah, I'm going to loop back to your comment earlier about the relationship between BCI and Abacus as we were doing this. That has been critical for us in iterating quickly on the UAT. So it's very easy for us to identify the people we need to speak with to resolve an issue that has popped up in UAT or in one of the data tables so that we can quickly get it resolved. That's absolutely helped the process move faster.
Definitely. And defining business owners and technical owners helps. So when a problem does pop up, Abacus was able to identify, okay, who's the best person to talk this through.
Right. And likewise for the BCI side, right?
Yeah.
All right. So how would you get started if you're considering doing something similar in your own organization? We started with building a case for identifying all of the flawed data and how that was impacting us as a company and as a team. What were the root causes? What were the pain points? Making a list of them and then starting to work through the ideas of how those can be solved or what kind of innovations are there. We were doing this ahead of our engagement with Abacus, kind of identifying these pain points. And I think we identified fairly early we needed a data lake type solution that we were jokingly calling the Blue Lagoon for a long time. And then Abacus came along and helped us solve for this. You want to be able to show what the advantages are going to be when you solve this problem. So what improvements are you going to see in your risk adjustment programs? Will there be efficiency improvements? And if so, what is your team going to focus on with the additional time that's freed up? And then what are the benefits of that work that they're then able to do? One of those for us was of the added capacity was the ability to start looking at things from a more innovative perspective and really digging into the data to identify opportunity that had been hidden or we just hadn't had time to adjust or adapt it. So it's really that sort of innovative side that was freed up for us from an efficiency standpoint. Are you going to have advantages from data accuracy? What are the compliance reputational or operational improvements that you're going to see with more accurate data? And then how does that impact your members and your providers? And not to mention your own collaboration across teams within the company. It's very helpful to recruit a C-suite champion. When I was first looking at this project, I realized that I was going to need IT support, very much their support. And so if I did not have the C-suite that they reported up through that champion involved and part of this project, that I probably would not be successful. So I set up a meeting with him early on, presented the problem, presented what I thought might be the solution. And it was very easy to get that person engaged and help me identify what next steps should be in engaging our tech resources internally. And then as the project progresses, having a C-suite champion is going to help you if you run into resource challenges or you need resources that you weren't anticipating originally, and helping to free those resources up so that you can be successful. Collaborating with your tech organization, kind of building on the last step. I am a business person. I have a little bit of data experience. And so there was a lot of technology in this that was new to me that I had to learn. And so I leveraged my tech organization to help vet the solution to make sure that it was something that was going to meet BCI's needs, that it was really going to do what we thought it was going to do. And I'll never forget, I set up a meeting with Abacus and some of our IT leadership for a half an hour. It was just a information, high level. They spoke for an hour and then asked me to set up another hour meeting. So the conversation went very well, and that was very helpful in getting our IT engaged in this project. And then, of course, every business has some sort of approval process. So making sure that as you're going through these steps, you're clearly documenting the business proposal, what needs to happen, what resources you need, what budget you need, and then taking those through the appropriate approval and budget process.
So expanding on what Leah just reviewed, to learn more on how to get started, you can find this white paper with the link shown here. So encourage you guys to download the white paper and read a little bit more. And then also the next link is to an assessment to understand where you sit on your data journey. This assessment has various questions and scoring to assess, how usable is your risk adjustment data today. Again, super helpful to get you started, and the link is shown right here. And I think with that, we will take questions.
Well, thank you, Leah and Jonathan. At this time, we're going to address some questions that came in during the presentation. And our first question is, I'm curious about the size of most issuers' risk adjustment teams. We're concerned we haven't properly staffed that area, but we're unsure what industry standard we should be comparing to.
That's a really good question. I've been in risk adjustment for about 10 years, and I've had a chance to talk to a lot of different health plans, and it always surprises me the variety in the structure and the size of the risk adjustment teams. Not only where they're sort of vertically aligned in the organization, it could be in an operations department, could be in a medical management type department, finance department, but also where they kind of place their choice for resources. So I don't know that I have a one-size-fits-all solution. We personally have a fairly evenly balanced data provider engagement team, a smaller team that's sort of doing the oversight on vendors and coding. We outsource a lot of our coding, so we do a lot of the oversight of that internally. Other teams I have talked to have had a lot of coding resources and less of the others. So I think probably the answer to this, and I know it's probably not the one that you were wanting, is you have to look at what you need, what you're able to do. And then if you're not able to do it, how do you outsource it? And how do you make sure that you're doing the right oversight for that? So I do think it is somewhat of a unique design for each health plan. And I think that's why there's probably not much benchmarking in that area.
Thank you. And our next question is, how is impact of HCC model changes accounted for?
Yeah, great question. I'll take that. So the risk score engine calculates HCCs and risk scores for all the versions, both historic and current models, automatically. So, for CMS, we're running both V24 and V28 at the same time, and then blending those scores or blending those HCC factors in the data tables that we're producing. But we can run any data set through the risk score engine independent of time period, and then have that risk score information and HCC captured dependent on the model. So there's a lot of flexibility there. And then as new models come out, it generally takes, a month or so for that new model to be incorporated in the risk score engine, and then we can distribute the latest model in the data solution. But we do run multiple versions concurrently, and we're not only running one model, and then the end user can have access to the results of the multiple models.
Yeah, I'm going to add on to that a little bit, because one of the things we struggled with prior was when CMS released a new model, the time it took for us internally to build that model out in order to be able to assess it left very little time for us to actually have influence on like a CMS comment period. So we've created a lot of efficiencies in how we're getting those models into it so that we can start using that data much earlier in the process.
Great, thank you both. Our next question is, what key goals or innovations are you prioritizing now that you have usable data?
So we are focusing a lot on our provider engagement side of things. We had previously built out a lot of sort of standard reporting for providers where we were giving them high-level metrics, which is great. Providers need that information. But in addition to that, they were really looking for what specifically can I do for my patient panel, or what documentation in my medical records needs to be changed so that we're ensuring that we're supporting it in the medical record, right? So our innovation and the new things that we're doing is really focusing on, to the extent that we can, personalizing the data that we're taking out to our providers. Obviously, we can't do that like a customized report for every single provider, but we can create a report that's looking at unspecified diagnosis code usage by providers or single source code usage by providers. We can look for trends in HCC capture, and then we can go look for charts. So maybe we're seeing a particular provider has a high level or high number of patients with a certain condition. We can look at what that capture looks like in claims, what it looks like in our retrospective chart review. We can provide some specific content to the providers to help where they're maybe not supporting it in the medical record, not using the right language, like linking language with the prescription, or where they might need to be using something like a history of diagnosis instead of an active diagnosis for certain high-risk conditions as well. So it's really the provider engagement focused side of things now that we have more usable data.
Okay, thank you. And our next question is, are there any strategies beyond value-based reimbursements that have worked to engage your providers further in your risk adjustment efforts?
I can start here. So with the data solution, first, a big thing that we highlighted was the timeliness, getting the most current data to the provider. I think just naturally gets them more engaged because they know it's right, they know it's timely, and they're not wasting their times. I will say with the data solution, we are also able to give a better history and a better cheat sheet of what's going on with the member. Both, what are the current captured conditions for this year, but also historically, what conditions has this member had in the prior 2 years? Things as also key stats as, when was the last time this member had an annual wellness visit? Because oftentimes AWVs are the best time to capture diagnoses, but also, when was the last time they went to their attributed PCP? If a member switched their PCP and the provider attribution logic is mapping them to their old PCP, we need to find a way to identify that and also educate the providers like, hey, they maybe once saw you, but maybe they're seeing somebody else, and having that data will help them, better manage their panel, and also BCI better, direct and have a better conversation with the providers on their performance in their value-based arrangements.
Thank you.
Hopefully that
Our
helps.
next question. Thanks, Jonathan. How do you make sure you're retrieving charts of high quality, namely easily readable? What % of charts are collected via direct EMR connections?
It's a great question. We absolutely still get charts that are not easily readable. I was just looking at one yesterday. We've been focusing on trying to increase our EMR connections. We don't have a high percentage of it currently, and part of that was the structure of our data warehousing was not easy for us to, if we created the EMR connection, we didn't necessarily have an efficient place for us to store and utilize that data. Now that we have this solution, we have the data lake up and running, our next step is actually to build out some clinical data store where we can house electronic medical records and getting them through EMR connections. And of course, if it's coming through in a data connection, you don't have to worry about a provider's handwriting. But we will never get to, I kind of suspect we may never get more than like 75% EMR connections just because of the provider structure and the provider population here in Idaho. We very much have some that are still readable or not easily readable because they're still handwritten.
Are you looking at more prospective and or concurrent risk adjustment solutions, or are you mostly focusing on retrospective?
Oh, good question.
Yeah, I can. Yeah. You want?
I've got some thoughts.
You want me to?
JT, who wants to go first? I was going to say we have, because the data was not efficient, it was very hard for us to get to a concurrent look on it. So we've had prospective and retrospective programs for years, and they've been functioning fairly good. I would like to see more of the work transitioning into the prospective or the concurrent risk adjustment solutions and less on the retrospective. Part of that is the EMR connections that we were just talking about, getting data in the door faster so that we're able to leverage it and use it for reporting faster. But also being able to have metrics and tracking and trending and being able to really identify those outliers is helping us shift more into a concurrent risk adjustment solution. What were your thoughts, JT?
Yeah, and just to highlight, the risk adjustment data solution is both for the ACA and MA market. You know, ACA is a concurrent model, and the ACA is a concurrent model, and obviously Medicare Advantage is prospective. So although it sits in one single data solution, we have both of those models that we're running, just to be clear.
All right, and our next question, how are BCI's other departments and functions leveraging or going to be able to leverage usable data designed for risk adjustment?
Sure. So I mentioned a little bit in the presentation how prior to this solution, our data lived in siloed sandboxes because we were sort of creating our own data sets for use. That was preventing us from sharing it with other data users in the company, like our healthcare operations team, where care management, care coordination lives, as well as our actuarial team. So one of the initial benefits that we've had is quickly able to give access to somebody on actuarial or another data analytics team in the company so that they can directly access our data. And then because we have standardized the business requirements and rules going into it, and it's not something that is specific to a certain use case for which we grabbed a certain set of data, there's a lot less training and explanation that has to happen in order for other areas of the company to utilize the data. So one of our biggest benefits is actually with the actuarial team being able to access this for their own day-to-day reporting.
Right, thank you. Do you have any experience working with self-funded commercial groups to integrate risk adjustment into their VB initiatives, or is this on the horizon?
So this is on. Yeah. You can start.
Go for it. I was going to say we don't have a whole lot of that at BCI.
Abacus is working with other clients to build building out a value-based program data solution, and that data solution has elements of the risk adjustment platform, such as the risk score engine, which calculates risk scores for the commercial population, calculating PMPMs, risk-adjusted PMPMs, linking it to the exact contract, the value-based contract, and also doing that financial reconciliation and automating that financial reconciliation for a value-based initiative. Be it, what is the arrangement? Is it, addressing care gaps? Is it managing total cost of care? Is that total cost of care budget set as a percent of premium, or is it, hitting a certain trend target? So we do have that, and we have the ability to build out multiple data solutions, not just value-based. We also have a HEDIS and quality/stars data solution. And I will say, we have the flexibility to come up with a data solution specific to a client's needs. So whether that's, some pieces of risk adjustment, some pieces of value-based, some pieces of quality, we can work with the client to scope that out and meet your needs.
Okay, and our next question is, how have or will the day-to-day work responsibilities of the risk adjustment team change since adopting, excuse me? What did you stop doing? What did you add? Or now that you aren't or won't be spending all that time merging and massaging data, what is your staff or you doing or going to do instead?
Yeah, I can tell you one thing we've stopped doing, and that is moving data around inefficiently. I don't know specifically from a day-to-day perspective. My analyst team is still doing analytics, right? We're just spending more time on the analytics that count, or the analytics that are going to help us move forward, and less time on keeping the lights on things that we've already built, right? So the real benefit of this is the innovation that's going to allow us to continue to grow.
And we're almost at the end of our scheduled time, speaker, so I'll turn it back to you for any closing remarks.
Nothing from me. Just wanted to say thank you again for attending. And again, if you have any questions, feel free to reach out to us. And I encourage you to read the white paper. And thank you again for your attention.
I agree. Just thank you for attendance. We appreciate it.
To our speakers, thank you for that great presentation and for sharing your thoughts today. And thank you to the audience for participating in the webinar. This concludes today's presentation. Thank you again and enjoy the rest of your day.